Welcome. Welcome to Kidney Conversations with ReMend. It's a webinar designed for patients by patients, and we have an honest, open discussion about kidney care. I'm Kiku Boyens. I'm the Executive Director for ReMend, which is a nonprofit organization dedicated to assisting people with kidney disease. We're a group of everyday people who've had either already successfully experienced dialysis, presently undergoing dialysis, or have received a transplant. ReMend provides peer-to-peer mentorship, guidance, and emotional support, and our goal is to encourage and empower those people who are on their kidney journey. Learn more at ReMend by visiting our website at remend.org. So this month is National Mental Health Awareness Month, and we're talking about mental health and its effects on chronic illness. And some of the things we'll be discussing today is: what is depression? Can you ever really be healed from depression? How does stress affect your health? And when you already have a chronic illness, and then caregiver depression. Chronic kidney disease is a lifelong condition, and the stress of living with a chronic progressive condition can affect your mental health. Depression and anxiety are very common with chronic kidney disease. They can appear in people affected in those who care for them throughout all stages of CKD, from diagnosis to dialysis, following transplantation, and even in deciding to start or withdraw from dialysis. One study by the National Library of Medicine found that 45.7% of participants receiving hemodialysis experienced anxiety, and 30% of them still had it 16 months later. Conditions such as stress, anxiety, depression, and substance use disorder can worsen symptoms. They may also make it harder to follow your treatment plan or practice the healthy habits you need to live well with CKD. But before we move on about this very important topic, we have some quick housekeeping items. We want to hear from you, so please send us your questions in the chat box. We'll answer questions throughout the broadcast and at the end if we've missed any. We also have a short survey you can complete anonymously, which we appreciate greatly. So let's begin. We have a wonderful panel this evening. Today we have Ms. Charmaine Griffith. She's a ReMend mentor. Cindy Polis, she is the Care Coordination Management Education Nurse at Balboa United. Cindy works with chronic kidney disease patients to help optimize a healthier lifestyle and educate patients on different modality options for dialysis, and she supports Balboa nephrology clinics covering San Diego County. We also would like to welcome Lupe Rodriguez. She's a licensed clinical social worker and program director of holistic addiction services at Spark Center for Development in Sacramento. She is also a certified yoga instructor. We also are happy to welcome Dr. Bijal Patel. He is a nephrologist and CEO at Balboa Nephrology. So everyone is here. Please turn on your camera so we can see your beautiful faces. Hello, folks. Thank you so much for being here. I want to ask you a few questions before we delve into everything here. Charmaine, I wondered if you'd tell us a little bit about your kidney journey and your mental state when you received your initial kidney diagnosis, or what you'd like to share with us about that.
Yeah. Thanks so much for having this topic. I think it's really important, and it's oftentimes overlooked or, undervalued, I guess. So when I was first diagnosed with, I knew that my kidneys were failing, but I was in such great denial that I just kept telling myself that I had to work out more, I had to eat better because I was so fatigued. And then when I finally got the news that my kidneys were at about 5% and that if I didn't start dialysis, I was going to die. It didn't hit me right away because everything was just so rushed, like dialysis started that day and I had already had my shunt in and, or my graft and all that. And so it didn't really hit me right away. It probably took me a couple of days to really understand, like, wow, this is like really happening. And it was just really a tough adjustment, even though I knew it was coming. I just felt a lot of loss, I guess. Like I felt like my whole life was going to be different, and it was, obviously it was, but how different, I didn't know. How was I going to adapt? How was I going to behave myself, so to speak? And because I'm never good at that. So it was just a really tough transition. But I came to understand that, um, it's really like a whole grieving process, that you go through the loss of the life that you had, and then you're trying to adjust, you're angry, angry at everybody, and so it's just really tough. But I think that once I got through that process and started accepting, that's when things started getting a little bit better. But it's like the nails on the wall. It's like I couldn't let go of that previous life. But yeah, it was tough. It was tough.
Thanks. Thank you so much for sharing
Yeah, you're
that.
welcome.
And I totally understand. I'm also a patient, so I get it's overwhelming, so
It
thank
is.
you so much for sharing. Um,
You're welcome.
Cindy, hello.
Hello.
I wanted to talk to you, ask you a couple questions. Much of your work,
Sure.
much of your work is focused on educating patients prior to being on dialysis. So in your experience, have many patients expressed their feelings about stress, depression, and or anxiety?
Absolutely. They get this sense of almost like hopelessness, like this bottomless pit.
Mhm.
And hopefully during the times that I get the opportunity to have these discussions with my patients, I can inspire them and give them their hope again and explain that there are options out there and there is good survival out there, and give them that hope again,
Mhm.
because without that hope, that kind of veers and goes into maybe medication noncompliance, treatment noncompliance, just very deflated in their care, not really wanting to advocate for themselves anymore. So I think I'm very honored that I get that opportunity to really come in and help steer the ship and give them that hope, and really hope to inspire them to know that they're not alone on this journey. And that's really what we're here to do, to
Right
help.
on. Thank you. Thank you, Cindy. Dr. Patel, welcome.
Thank you.
So I have a couple of questions for you too. How long have you been a nephrologist, and what was the deciding factor in choosing nephrology as your specialty?
So I've been a nephrologist for 15 years, and all those 15 years where have been at Balboa Nephrology. I used to be a primary care doctor. Actually, I worked
Mm.
3 years as an internal medicine doctor, and I just always loved the continuity of care and the relationships that I had with patients. But I always did feel that, I wanted to concentrate a little bit more um, on a specific field, and nephrology allowed me to really concentrate on still not lose that relationship, but also be able to be a part of, a really tough process for patients in going through dialysis, but then be a part of something like transplant where, overnight you have the opportunity to take somebody's life that has been very burdened, let's say, to then all of a sudden have this amazing kind of change. And I think there's only two reasons why people want to go to the hospital. I think one is to get a transplant and the other is to have a baby. And so, I just wanted to be part of that.
Mhm.
I would say the other thing is that, I had two uncles that have kidney failure and were on dialysis, and both have passed now. But one of my other uncles gave gave a kidney to one of my other uncles, and one of my uncles would send me money when I was in medical school, and I think that was, pretty special. That at that time, again, it wasn't like I was going through medical school thinking, oh, I want to be a doctor, I want to be a kidney doctor, but I think all those things kind of played a big role
Right,
in why I'm here today.
right. But what are some of the biggest changes you've noticed in kidney care since you've been a physician?
Well, the biggest thing overall is that, I think that for so long, people were just happy with living, like, our focus for in medicine has been to increase quantity of life. And, whether you're on home dialysis or in-center dialysis, a lot of times people say, well, both you live the same amount of time. But I think the focus really now has been on how do we make sure that people's lives are better and that they're thriving. And yes, we want people to live longer, but most patients don't want to live longer if they're suffering or they're miserable. And so I think the focus really is now more on having a better quality of life, thriving, being able to work, doing the things that you want to do, less fear, more control. And then we talk about, here's some of the benefits too. You do live longer, or you get a better chance to get a transplant. I think that's the one big thing. The second big thing, I think, is that the healthcare system has kind of looked or never really looked at kidney disease or kidney care much. It was kind of like a cost center. It's like, well, it's, what was more in the news would be more about orthopedic surgery or cardiac disease and things like that. But really, the burden on patients with kidney disease is so great. And what I really am excited about is the new surge of interest and even money being thrown towards trying to improve kidney care. And I think that's really been the biggest thing. And I'll just say the last thing is that, one of the biggest pieces of legislation was in 1973 when Richard Nixon passed a law to basically have all patients with kidney failure be covered with dialysis. But in 2019, the Trump administration also passed what I think is the second biggest piece of legislation called the Advancing American Kidney Health Executive Order, which really has pushed this desire to have many more transplants and many more patients on home dialysis and preventing progression of kidney disease. And so that extra interest and extra money and extra information or extra payment models to help doctors and healthcare systems provide better care is now upon us. And so I think it's a really special time. But we have a lot of smart people in kidney care that are working hard to be able to utilize some of these resources so that we can help our patients better. Because to be honest, we haven't been doing a great job.
Well, and that's kind of the basis for value-based care. That's scratching the surface of what that's all about. So thank you so much for sharing that. And we have Miss Lupe Rodriguez. I wanted to ask you a couple of questions, just really quick. Tell us a little bit about, being a licensed clinical social worker with Spark Center for Self-Development.
I belong to a small group practice here in Sacramento. I've been with Spark for about three plus years. What's amazing about Spark is that there's so much autonomy for us to be able to really specialize as providers in what it is that we love, and to be able to do it in a way that is very creative. We have so much autonomy in our programs and in how we approach our clients. And I come from a long history of working with substance misuse and numbing behaviors. And so when I got hired on, it was primarily to do addiction services through a harm reduction lens. But over the last 3.5 years, it's kind of, I'm doing depression, I'm doing anxiety, I'm doing lots of couples counseling. Especially with COVID, there was just a need for help in so many different departments. And so, just kind of doing it all.
And that's why we thought this would be a great discussion to include Lupe from Spark Center, because mental illness not only affects kidney patients, but it's a anyone with chronic illness, I'm sure, is going to have a bout of depression. I mean, it's a change of life, when you're diagnosed with something as serious as kidney disease or any other chronic illness. So thank you for being here, Lupe. I wanted to ask you one more question. Are social workers able to diagnose mental illness?
I want to answer that in a very careful way because it varies by state. Right. The boards by every state very differently of what social workers can and cannot do. I am a licensed clinical social worker, which means, yes, as a licensed clinical social worker, I have the clinical ability to diagnose. I'm sometimes in hospital settings, which is what a lot of, I imagine, patients that are going through chronic illness issues will see are some social workers that are not yet possibly licensed and are still interns. And in those settings, oftentimes my understanding is a lot of those social workers are there for triage. So they're there to do these really quick assessments and then just kind of hand you. And again, if I'm misspeaking, it's been a while since I've worked in a hospital setting, but from, back in my Kaiser days and my UC Davis days, it was, we meet someone, we give them a really 10-15 minute rundown of what we think we understand about them. And then we give them a pamphlet and send them on their way. And that pamphlet might not be updated. And they also might be calling people that are no longer available to offer services. And so in California, my understanding is yes, licensed clinical social workers can or do and can diagnose. Not all hospital social workers are licensed and therefore might not have that ability to do so. And if I'm misspeaking to the board, I'm really, really sorry. I didn't look at the board updated regularly. They change them all the time. So they could have changed them from yesterday when I looked. So
no, I
that's
appreciate
my latest
it.
understanding.
I'm sorry I threw that on you. I apologize about that. But since you're chatting, let's talk about what is depression.
Okay, and so because I'm here from as a licensed clinical social worker, my hope is to be able to talk about depression in a way that is both non-stigmatizing, right, and non-pathologizing, because one, depression is so common; it's everywhere these days, right? And so to feel that or to feel like you're carrying that should be something that we're carrying without shame or feeling like now something is wrong with me. And depression can vary the symptoms can vary from mild to very severe. And it can be it can be loss of interest in pleasurable activities that we just, we once found pleasurable, now that we don't, fatigue, poor concentration, and some of the bigger things we see is like, loss of libido. And that can also be that when you get on, if you are depressed and then you get on these depression medications, some of them have pretty intense side effects like weight gain and all this stuff. It doesn't necessarily make you feel like you want to, it doesn't really promote a high libido, right? So then we have that. And then I think, what I see the most is feelings of hopelessness. And I think Cindy touched on that, feelings of hopelessness, worthlessness. And then when we get to the more severe depression is intention or ideation of suicide, which can also be very common with severe depression.
And Dr. Patel, do you feel a patient's mental state can directly affect their medication and treatment adherence, kind of going off of what Lupe mentioned?
100%. I mean, I think part of our goal is we see a lot of people working out, just generally people working out to build their physical strength or physical reserve. But how many people out there actually go out to do things to build their mental reserve and their mental health? I think that we kind of just say, well, this is our baseline is our mental state, and then anything else is just lower. If you don't have this, a lot of our patients are going through lots of different things. I can tell you, when you don't have your health, nothing else really matters. So when the nephrologist or any of your doctors tell you, hey, go ahead, take this medicine, take this phosphate binder, it'll lower your phosphorus. I think for most patients, they don't see the connection of how is that going to help me feel better? I don't feel bad for one, or if I feel bad, how does lowering my phosphorus help me? And so it's really difficult to say, hey, I took these pills, 3 pills every meal, and then to say, gosh, I guess I'm better, but I don't feel it. My doctor tells me that. So I think it's very important, and really critical for mental health to be as strong as possible and to get the support you need. A lot of times people are going through denial, as Charmaine had mentioned. And if you have denial, you can't really, even when we educate you, you're not really hearing what we're saying. And sometimes, the time constraints that we have with a lot of physicians and the way the healthcare system is set up, physicians want to spend more time. It's just that the way the healthcare system is set up sometimes limits that time. And really, to feel better and to feel supported for a patient, I think it does take more time. And so I think what we're trying to figure out is, how do we use more people, whether it's a licensed, clinical social worker or a coordinator, care manager, nurse, or physicians, or telehealth, to kind of fill in the gaps. Because just because I see a patient for 20 minutes or 30 minutes once every 4 months, I'm not sure that's enough for what our patients' needs are.
So when you have a patient that maybe you can notice their depression, they're in a depressive state, what do you do? Like, how do you approach that when you see a patient that is going through that?
Yeah, well, I mean, I just tell them I notice and I validate their feelings. And like Lupe said, that it's pretty normal. In fact, it's pretty abnormal if you don't feel kind of down or depressed or, sad about or frustrated about something, where we're telling, as doctors, we're telling someone that may not have any symptoms that, oh, you're actually sick, and that you have something that is maybe coming, that the patient is hearing, okay, well, what do you mean dialysis? They may or may not know about it, but most people have heard something about it. So they're thinking like, okay, I'm going to lose control of my life. I'm not going to be able to do the things I want to do. And there's that fear of the unknown, and that fear of the unknown is debilitating. And so, I just tell them also that, you're not alone, that we are going to be here to help you through this, and no matter what, whether it's your family that you're close to or you're not, or friends or whatever, a lot of times people feel alienated, they feel alone. Heck, the COVID has made it way worse. And I said, no matter what, as your doctor, I don't want to, I just want to make sure you're never alone.
Right on. And I was going to ask, how do you think depression contributes to the progression of chronic disease? I just, from my own experience, quite some time ago, when I was diagnosed, I was in denial, just like you mentioned, and I didn't know anything about dialysis. What I did know was you had to have a fistula in your arm, and I knew I just didn't want to do that. And I had no one to talk to about it. I was living with my best friend, Brenda, and I spoke with her about it, but, not speaking to somebody who's been through it was difficult. So when I went to my first nephrology appointment, I was freaked out, and I saw someone in there that had a fistula who hadn't been taking care of herself, and it was infected. And I just thought, oh my God, what am I doing? What's going to happen? I don't want to go on dialysis, so I know that treatment adherence is a big thing. And luckily I spoke with somebody. I went into the exam room, and a nurse explained, I was bawling. I'm not a crier, by the way, but I was bawling, and I said, I can't do this. I don't know what dialysis is all about. I'm not going to do it. And she said, well, you're not going to be like that. You're going to take care of yourself. And this is, you have options. And so she explained to me, and her name is Annette Oat. I always talk about her. But she changed my life. Just, having a simple conversation, 10 minutes before the physician came in, really changed my life. And so I wanted to also have Charmaine mention, she had a story about her experience when she was not diagnosed, but just what she was going through mentally as well.
Yeah, thanks, Kiku. I know Annette helps so many people. So I didn't have the pleasure of meeting Annette back when I was sick, but anyway, yeah, when I was switching modalities, is when everything kind of kicked off for me. I was on, in center for the second time, only 6 months, and in center was really hard for me. It was, and mostly because of non-compliance. I can own that now. I was very active. And so, I had in my mindset that, okay, I got to drink so much water every day. And like, no, you can't do that now. And, just all the phosphorus foods. And back then, like trying to get a kidney diet together was just like, ugh. It was just like really disgusting. But so anyway, so when I went over to peritoneal dialysis, I just, man, it was just, I had like my phosphorus was so high for so long that it was pulling calcium from my bones and putting it in my blood. I couldn't get it down. Even I did try, but at that point it was just so high, and that was a lot of what was making me sick. And, I couldn't sleep. I had insomnia really bad. I mean, up for days and nights at a time. Like not this insomnia stuff that, that's this this cultural, oh, I have insomnia. No, it was real. I couldn't sleep. And then when I'd finally go to sleep, then my restless leg would kick in and then I'd be back up again. So it was really tough. I couldn't walk, because my bones were so bad. And I had to be carried to the car. I had to be carried into the store or get the little cart. And, it was really bad. And I remember sitting, me and my husband at the time, like we were sleeping in different rooms because I was up all night, like literally I couldn't sleep. And so we were like college buddies at that time. And I just remember, like thinking to myself, like I didn't want to take my own life, but I finally came to a place of understanding how people could. And I'm getting emotional talking about it because it was it was just a really difficult time. And
How do you,
because
sorry, go ahead.
I was just going to say that that it was just, I didn't really know like how or when it was going to get better. And just like, like you had said, Kiko, there was nobody around, like I had my husband, I was still working, oddly enough, and still trying to live, my best life, so to speak. And I was just in so much pain from my bones, and from not sleeping. And I remember doing peritoneal dialysis and being so tired that when I was standing up and draining, like my manual, like I literally fell over because I just couldn't, like, it was a horrible, dark time.
Well, how do you think you got through it?
That's a good question. I mean, I think it just came to a place of acceptance and just me wanting to fight. It's like, you have to get to a place of like chronic crossing over, it's like where, like, what would I say to somebody in this position? And what I would say to them is I would ask them like, well, what are the good things in your life? What brings you happiness? What brings you joy? And, I had a beautiful home and I had a loving husband at the time who was trying his best to figure out what the heck was going on and how he could support me the best. He didn't know, he had no idea how to be, a caretaker for a sick wife, he just didn't know. And so, so I don't know. I just think that, after peritoneal dialysis, like that took time to help me to feel better, because PD was every day, and it just took time. But during that time, like I just forced myself to get out of it, like just to appreciate the smaller things in life, like the simpler thing, like, okay, so I can't travel right now. Okay, but what can I do? I have a beautiful view outside of my backyard that I never appreciated before. So I would sit outside, and spend time, with my dog. At the time, I had a Great Dane at the time. And so just things like that. And then eventually it got better. And I think that's the big thing we have to remember is that it's not a quick solution. We didn't get here overnight. And so boy, that was a really dark place there.
Yeah, I'm
during that
sorry
time.
that you went through that. I
No,
but I
no,
do want to, and I thank you so much for sharing that. That's,
yeah.
I know that's difficult. Um, I wanted to ask a question of our three professionals here. If you're concerned about someone's state of mind, like both, you know, Charmaine and myself at the time, how would you approach the situation? Lupe?
You know, I think that the biggest thing that we have to make sure that we are aware of is that no matter where a person is in their illness, whether it's with mental health or their chronic illness, is that they are the power agent and the change agent in their life. And so to never try to come in, at least as a social worker, you know, try not to come in as an expert of someone's life. And so if I am noticing that somebody is really struggling with what's going on in their life, my hope is that, and it's luckily so far it has been the case, is that we've developed enough rapport where I can comfortably say to them, you know, I know that there's this investment that we have in our friendship or in this relationship that we have together. And because I'm so concerned and I've been working with you for so long and I'm seeing these changes in you, you know, I'm wondering if there's anything that I can do, right, to support you where you're at. But the biggest thing is that I have to make sure that I'm going to meet them where they're at and not say, you know, this is what I'm noticing from you and this is what you need to change. Because for most of my clients that are dealing with chronic illness, they're being told left and right what they need to do, what needs to change, what needs to happen. And for a lot of them, they just come into my office feeling powerless. I have no power over my life. Like I'm not an expert in my life. And so when I am, you know, and part of also being a therapist is we also always have to ask, you know, are you planning on killing yourself? Right. Because it's a huge one. We just have to make sure, like, are there any suicidal ideations, intents, plans, all of that. We have to make sure that is stated. And even if it feels really uncomfortable to bring it up in the room of just like, I have to say it. I have to make sure that, you know, we approach that question as uncomfortable as it is. And then also, how can I meet you somewhere where we can make some sort of change that can make this even a little bit better? Right. And to sometimes be okay with them not knowing, and both of us just kind of sitting with the discomfort of like, yeah, this is really crappy where you're at, and it really feels like it's kind of hopeless. And then just sitting with that sadness too. And sometimes that in itself can be helpful of like, you know, I don't know, I am an expert on my life, and yet it also feels hopeless. And here I am with my therapist, and she doesn't know how to help me. And we're just kind of going to sit on this couch together and just be sad.
Right. Right. Nope. I get that. Cindy, how about you? Like when you're speaking with patients, how do you approach the situation if they mention that they're depressed, they feel hopeless?
Sometimes they don't come out and say that they're depressed, but you know, I feel like I have a good sense, my intuition on the dialogue, the engagement on the conversation, their tone, because a lot of this work that I do is on the telephone. So I think it's important to really be in tune with the patient and their voice and the feedback. So I think maybe just kind of my tone and my delivery and my questions and how are you feeling and the sincerity and my voice and really how I'm here to really help you. And maybe just find out, like, what are you doing? You know, what have you been up to? And just kind of build that rapport again. And I think for anybody who's struggling with depression, it's incremental dosing, you know, little baby steps, and go with that, you know, and maybe we just have 3 baby steps today and we talk a little bit about what's bothering them or their fears. That's a big trigger for depression. And let's just figure out how we can talk together about what those fears are and maybe have some guidance and insight on how to manage those fears. And also, what are your worries? and let's guide those worries, and let's find some tools to use to support those worries and minimize that worry box and make it as small as possible and clean out that worry box when you can, right?
Who mentioned the worry box the other day?
Love the worry box.
I love the worry box. Was
No.
it Lupe or was it Cindy?
No, I mentioned putting the worry box in the closet. I think it was Charmaine, right? Or maybe it was
Cindy.
I think it was
Yeah.
Cindy. Yeah.
Yeah,
The worry
right.
box. I
That
love
sounds
Worry
like
box.
a Cindy thing. Worry
Yeah,
box.
because you got to keep it small if you can, you know. And
Yeah.
you know, I deal with a lot of people that are depressed in my work life and my social life and my family and mental health in my family. So I get it. And you know, feedback and support and incremental dialogue and that closeness and giving them tools and any kind of sickness is very, very scary. So yeah, I don't know if I answered the question.
Well, someone just asked, what's a worry box?
Yeah.
Matthew. Matthew asked, what's a worry box? You want to
A worry
explain?
box. Yeah. A worry box are things when you're going through your day. If you have a chronic illness, okay, what does this mean? How am I going to tell my family? How is this going to make me feel? You know, all those questions you're asking yourself through the day. How are my kids going to handle this? How are my kids feeling? Am I going to keep my job? Am I going to be able to buy gas? Can I get those groceries? You know, those are worries, worries, right? Minimize those worries or address them and then put it away. Okay, gas is expensive. Yeah, okay, that sucks. But you know, when you have to drive, well, okay, I'll get a little bit today. Forget about that worry, put it away. Or, you know, have that conversation maybe with that family member that you are dreading on having and sharing that emotion, and then put it away. And don't look at that worry box or don't address the worry box till you need to. I don't know if that answers his question.
I hope that was helpful, Matthew. Thank you, Cindy.
Can I comment on the worry box?
Yeah.
Please.
So my clients and I do that as well. And so we just call it like, okay, we're going to have 10 minutes where we just worry about whatever is going on in your life, right? And we're going to give it this 10-minute focus. And you can tell me everything. And then after that, because so much of their worries are out of their control, right? I either incorporate that yoga part in me that is like, okay, now we're going to do some deep breathing over this, or we're going to do some like downward dogs and alleviate some of the anxiety over it. We got 10 minutes. I validated your worries. The price of gas. Yeah. Price of groceries, all these things, like all these appointments you have this week, they're all super valid. But guess what? Even if we decided to spend the whole hour doing the worry box, it wouldn't change these things that are right now out of your control. So why don't we minimize it to the 10 minutes? And I will give you all my focus and attention. And I will validate the heck out of like, yeah, that's all super difficult and super tough. But then if we focus the whole 50 minutes, like it's not going to change it. It's not going to make it better. The price of gas is going to go down. Groceries aren't going to go down while we're in here. And so minimizing the worry so that we can, one, validate it, but also we can't get stuck in it.
Right. Absolutely.
Thank you. Thank you. Dr. Patel, I think, let me repeat the question. If you're concerned about someone's state of mind, was that the question? I don't even remember what the question was. It was all good stuff we were just talking about.
I mean, I can just kind of, speak to some of the comments. I think that, you know, what I also try to do is try to have them reach out to, you know, their behavior, you know, a lot of times they don't know how to reach out to behavioral health. And so sometimes I help them like, let me see your card, your insurance card, you can call this number. But I have to say it is difficult because they're not always, they don't necessarily have a relationship already with a counselor or a MFT or psychologist, LCSW. But I do try to encourage them. I try to reach out to their primary care doctor to kind of help them encourage so that they have some conversations. But what I've heard mostly here is that really this problem is really needs to be addressed by so many different people, and people like Cindy and Lupe. I mean, I just love that how you described all this, and it's just so important for us as physicians to not forget that there's so many other people out there to help patients. The hard part is that our healthcare system is disjointed. And so it's not always so easy to get to the people. And so some of the things I will say, I don't know if this is a plug for Balboa nephrology, but some of the things that we are trying to do in Balboa nephrology is to break down those barriers and to really have a product and a care product that really has people like Cindy. I mean, Cindy is in our medical group, and really take advantage of all these other resources and experts that are better at talking to the patient than many of the physicians. And so I really appreciate both Cindy and Lupe, your expertise in this, and the help that you offer our patients. And I would just ask all patients to consider that you deserve the help, you need the help, and there's people that want to help. And I can just see the passion in Cindy and Lupe's just voice of how much they want to help. And
Absolutely. Yeah.
Charmaine, did you
Yeah.
have a question?
Yeah, so I'm sorry, my TV is acting crazy. So I just had a question for Lupe. You had mentioned about, identifying somebody who's showing like depressive states or like traits or characteristics and things like that. And then you had mentioned about, it was in the beginning of the conversation, so I might not get the terminology right, but you had mentioned about like chronic depression or something like getting more serious.
Right.
And so is there a difference between is there such a thing as like situational depression, just kind of happening on the surface and it's just because of what's happening right now, or is it like just always something that's going to go into a deeper state, even though like the situation might get better and things like that? Would you recommend that somebody still reach out or?
Right. And so, I think that was actually one of the questions that Kiku had wanted me to ask, if people can ever be healed from depression. And I had asked Kiku if I could use the words in recovery from depression instead, because yes, I think a lot of people's depression comes from being caught in situations that one are unexpected, right? And then there's also a lot of uncertainty ahead of what happens next, right? And and then depression and anxiety go hand in hand oftentimes, right? So I'm now part of this situation that I didn't expect happening, chronic illness being, a huge one, right? And then the uncertainty that lies ahead is going to bring about some anxiety, right? Does that mean that we're always in that? No, I actually think that a huge part of people being able to recover from that is that there's a recovery of a sense of self. And what I must note there is that, we don't get the self back that we had, and I think I mentioned this on Tuesday when we did a mock, run through of, one of my really good friends is dealing with lupus and kidney failure. And so, her biggest thing was in order for me to get from a place where I was less depressed and less anxious, I had to let go of the thought that I was ever going to have that person back. Right. And so now I have this acceptance of this new sense of self, this new person, right? And so we can recover and we can get better from it, right? It is not something that we have forever, but it does take about some acceptance of, can I grieve the person that I used to be?
Right.
As hard as that, for a lot of that, it's a lot of ableism that I used to be able to do to can I love this new person that is going to have to be doing all of these things? And if I can, then yeah, depression and anxiety can subside, because we're learning to live in a state of this new person that I am. I can love this person and I can accept this person. Does that answer your question, Charmaine?
That was great.
Yeah, thank you so much. Yeah.
We are buzzing through time. So there are a couple of things I want to get through here. I wanted to touch base on tips on supporting someone who's depressed. And I have some of those listed here. Ask the person if they'd like any practical assistance with tasks. Talk about your feelings you both are having. Acknowledge their feelings and ask them to acknowledge yours. Opening the lines of communication is super important to prevent misunderstandings. And respect what the person is saying about their own experience. They're experts in their lives, just as Lupe was sharing, and encourage eating a healthy diet and exercise. Respect the person's privacy and confidentiality unless you're concerned that the person is at risk of harming themselves or others. And this was my favorite line that Lupe mentioned: meet the person where they're at, make them a power agent. That's a cool line. And, you know, we have a really cool quote from, or not quote, but comment from a viewer, Patrick, kind of a suggestion. The concept of generative hobbies, I haven't heard of that before. Have you guys heard of that? Can be beneficial for this type of patient. My father-in-law used graph paper to trend his blood pressure versus time versus fluid and removal and weight while on PD, which is peritoneal dialysis. All this effort was tremendously stressful, and he was on the right track by finding a hobby. Unfortunately, his hobby was smoking. I'm trying to advance the idea of introducing patients to generative hobbies, and especially hobbies that create community. That's cool.
That's very cool.
Thanks for sharing that, Patrick. What do you guys think about that, Lupe? Is there taking your mind off of something such as having a hobby can be helpful in not healing, but what did you say?
Recovering your sense of
Recovering.
self.
Yes. So
Yeah.
what are your thoughts on that?
Yeah, I mean, even if this person's hobby was smoking, right? Like even in those moments, maybe like they weren't identifying as a person that was sick or a person that was ill. And so anytime we can take a vacation from these identities, that can be so painful. And I'm not advocating for everyone that has chronic illness to go out and smoke cigarettes. So please don't, like, it's not right. Or to,
right. That's not what we're saying.
That's not what we're saying here. No, but I'm saying is that, you know, we already live in a society that is so hard enough to just deal with head on, and then add a chronic illness or add some sort of suffering to that. And yes, we're going to want to numb. And if we can numb with a hobby that is a healthy one, you know, but I think we talked about this on Tuesday, you know, I really hesitate to, when I'm working with clients with chronic illness, you know, even as the yoga instructor who's trying to, you know, figure out what kind of yoga can people do depending on which illness they're doing. I hesitate to say, you know, yeah, go exercise, go hydrate, because, you know, then I heard, you know, I think I heard from you, Kiko, well, sometimes when you're on dialysis, you can't hydrate. And so, or sometimes, you know, certain diets that I would recommend as a yoga instructor aren't medically appropriate for some clients. And so it's making sure that whatever hobby that they're doing, if it provides them like a temporary escape from this identity, this hat they're wearing as like someone that is sick or someone that like is potentially not going to make it very long. Like, I'm all about the hobby. I mean, even if the hobby is smoking.
Yeah.
I mean, I'm in the harm reduction world, right? So, I mean, I'm all about, like, if you can do it safer, maybe hydrate, whatever it is that you can do that goes along with smoking, that would be less effect, you know, less negative effects on the kidneys and the pancreas and all of that. But yeah.
Right. Gotcha. Hey, I want to jump to an important topic. I feel that there isn't a lot of information about this, especially in the kidney community, is caregiver support. I've had several people reach out to me about that. And unfortunately, you know, I didn't have a ton of information at the time. I do have some resources that I'm going to put up in a second, but caring for a loved one is no easy task. And there's approximately 40 million Americans that serve as family caregivers today with no formal medical training. A majority of family caregivers are responsible for attending to the emotional and physical needs of a loved one, all while typically working a 9-to-5 job too, and caring for their own family. So what are some of the strategies to know when taking on the role of caregiver? And with that question, I want to ask you, Dr. Patel, like, when you are visiting with patients, typically patients bring someone in with them. If, you know, have you had interactions with patients with their caregivers? And if so, like, what's that like? What's your conversation like?
Yeah, I think that, anytime you can see a patient that has had multiple medical problems or has difficulty walking or is on daily peritoneal dialysis or even going back and forth to an in-center dialysis clinic, you can see that can be a burden on the caregiver, the loved one. And so oftentimes, if I see somebody that's in the room with them, and I ask them really just, how are they doing? And usually they just kind of brush it off, say, yeah, I'm fine, fine. Yeah.
Yeah.
How's my mom doing? And then I ask them, no, I'm actually seriously, like, this is a lot. Like, how are you doing? And then they usually just oftentimes start crying. And I think that they're so used to nobody, like they're not used to people asking them how they're doing. Everybody's focused on, oh, my mom has one leg and is in a wheelchair. Obviously, everybody's worried about that person. But with chronic illness, just as if you're a caregiver or a patient with kidney disease, a lot of times people look fine. And so I think it's very important to address that, because if that person gets sick, then the patient is obviously worse off. And I remind them that, in the hospital, when we have a patient that's in the hospital for 7 days, a full-time nurse works 36 hours. And there's 168 hours in the week. And so you have multiple people, nurses and aides around the clock helping that person. And they're basically doing the job of a nurse and aide, but 168 hours a week. And so I try to kind of mobilize resources or opportunities to talk to them about, hey, you know what, we can put, if they're on home dialysis, we can put your mom in a center dialysis for 2 weeks just to give you a break. Or there's respite, or there's respite, even if your mom is in a skilled nursing facility for a short period of time, just so you can take that vacation break so that you can recharge, because it's very important. And I would say that to our own physicians in our group, and that you need to take time off so that you can recharge, so that when you're back, you're really all in. And so I that's kind of how I approach it with the caregivers.
Thank you. What is, Lupe, what is caregiver burnout?
Wow. I mean, it's something that we see in our practice often. It is caregivers that, I want to preface this with saying that in my experience, we don't live in a society that really gives much allowance for caregivers to be able to actually, like Dr. Patel said, this is 168 hours a week these caregivers are on. And for a lot of these caregivers, they're still working full-time jobs. Some of them are still shopping their kids to school and to sports. And so they are not only having to still do, and then the financial burden of chronic illness, right? They're making sure they have to keep this job and they have to keep the health insurance because they got to keep this family going.
Right.
And so the burnout, I think, comes from it's now one, and especially if, when I'm working with clients where it's the partner is the person that's ill, right? And so then there's whether it's the husband or the wife that is responsible for then having to take care of everything around the house and be the caregiver. And what I've noticed from my caregivers is that they are often praised, which I think is, we really have to this is a good takeaway that I would hope for, just people watching, that we praise people often for being so selfless when they're caregivers. And what we're essentially telling them is like, really good job, just because it could completely dismissing your own needs, completely dismissing what it is that you need from your life, and just being there for your children, your job, and this person that is ailing. And not only that, but oftentimes my caregivers, this is both on a personal and a professional level, report that, the person they're caring for is angry and is really not stoked with being sick. And guess who gets the dumping of that, right? Is the caregiver. And that caregiver, and I think I mentioned this on Tuesday, finding a caregiver support group in person is really hard. And I have some caregivers who don't want to do Zoom online support groups because they're in the same house as the person that they're taking care of, and they are traumatized in that house. They need a break. They need to go somewhere else where they can be contained and somebody else can say to them, I'm really sorry you're going through this. They don't want to do it, in the room next to the person that they're taking care of, and next to their 3 kids, and having to make dinner next, and all of that. And so the caregiver burnout is they've lost their sense of self, and they're literally living for trying to take care of this person that is ailing. And what, you also see the research of a lot of caregivers pass away first.
That's what happened in my family. My mom passed first. Yeah.
Right. Just so much cortisol released from being a caregiver, right? You're just full of stress hormones. And so caregiver burnout, it's everywhere now, because people are living to be older. And so there's a lot more people that are in that role of caregiver, and yet it's very expensive to live. So you can't just retire and become a full-time caregiver. Right.
Right. Thank you. I have, some resources for caregivers that I found, and want to share that, and we'll just keep the conversation going while that's up on the screen. Some that I had no idea. I didn't know about the Today's Caregiver magazine. That's pretty cool. But then also Davita and Fresenius Care, they each of those organizations have care partners and kidney care communities, things that you can look into about caregiver information. There's caregiver.org. And of course, National Kidney Foundation has family and caregiver resources as well. While we're talking about this, I had a couple of questions that, came through, and I haven't been focusing on those. Oh, well, look who this is. Brenda Vaccaro. She's a founder of Spark Center for Self-Development. She says, I love your focus on harm reduction in your work, Lupe. Learning about this from you has changed my own work as a therapist working with patients. How can we apply harm reduction to chronic illness and mental health? And in addition to that, how might harm reduction apply to caregiving?
I mean, I think, as I mentioned earlier, as far as applying harm reduction is meeting the client where they're at. Harm reduction is what can we do to reduce the harm associated with your behaviors or the current conditions in your life, right? And and sometimes it can be the smallest of baby steps, because the last thing I want to do is to scare someone away day one by saying, so my whole gig is that I do holistic health, right? So I'm not only going to change, we're going to work on what's going on in the mind. We're going to work on what's going on in your diet. We're going to work on your exercise. But if I were to tell you that from day one, you're going to leave my office and you're never going to come back. And so, sometimes if I can get a caregiver to go for a 10-minute walk between now and next session, right? Or, hey, if I give you this 5-minute meditation on, can you take a bath between now and next week? And so harm reduction is what can you give me, right? Like that would help you between now and next session. And I will make it just so possible that it can be a 5-10 minute thing. Right. And so the hope is that, and I do have caregivers that I'm working with for years now that, like, obviously now they're getting massages, and now they're, because they're, gotten rid of some of that guilt around, like, I know I'm a survivor, but in order for me to survive and take care of take care of this person that's ill, I need to take care of myself. So I do deserve a massage. I do need to go get my nails done. It took time though. It initially started with, like, hey, how about between now and next session, you take a 5-minute walk? That's harm reduction. It's really starting with baby steps.
Okay.
Did I answer the question?
You did. Thank you.
Okay.
And very well. Thank you. And we're coming to, we're already at an hour, but before we close out, there's so much more to talk about. I mean, this is such an important topic. And I do want to say thank you ahead of time, because this has been awesome, but there's just so much more we could go into. In closing, before we close out, I'd like to ask our panelists, what would you like our viewers to take away from today's discussion? And let's see. Cindy.
Wow. I just hope it was informative in terms of, I think, I think everybody has a little bit of depression, and I think we just all cope with it a little bit different. And there's so much illness all around us. And, an emotion lasts for 90 seconds, right? But a mood can last longer. But if you're mindful about that mood, have the emotion, like Lupe was saying, but then really acknowledge the mood and maybe be mindful of the mood and figure out a way to change the mood. So I think, I don't know, I just hope that a lot of this was helpful for our audience because it was very helpful for me. And thank you, Lupe. You brought some really good points into the conversation for me to really help my patients and give them more insight based on what you said today. So I appreciate it.
I love it.
Yeah, I love it too.
Charmaine, what would you like people to take away from today's conversation?
I guess the big thing as a patient to just understand that your emotions and what you're feeling are okay, whatever that is. That you don't have to be that strong warrior person, like breaking down and talking to people doesn't make you weak. It makes you human, and it's just so important that that when you're feeling a certain way or not, just to communicate with the resources that you have available to you. And you're not alone in this journey at all. You can always reach out to ReMend.
Right. Reach out to ReMend, remend.org.
Yeah.
While I know I have two more folks I would like to give a few moments to chat, but I think I want to include this slide because I feel it's really important. If you or someone is considering suicide, please get help from a crisis or suicide prevention hotline. Call the National Suicide Prevention Lifeline at 800-273-8255. I'm going to leave that up for a little bit, but I would like to know, Dr. Patel, what would you like people to take away from today's conversation?
Yeah, gosh, there's so much. And I would just say, we're all learning. I've learned a lot just today, even just being on this call. And I think that the main thing I would say is that, our patients are not alone. And if you don't feel comfortable or you don't feel like you can share with the people that care for you, whether it's your physician or your counselor or primary care doctor, I think it's okay to also seek somebody else that may fit better for you. Because I think sometimes what I see is that people are, I've been set up with this person, and it's just like any relationship. The relationship has to work both ways. There has to be trust. And sometimes I hear from patients that they just didn't feel comfortable talking to their physician or whoever that is. And so it's sometimes just a different personality or whatever, but I would just say, ask the nurses, ask the doctors. I mean, just make sure you get the help that you need, because there are so many people that really do want to help, and it's not just physicians. And I hope that with ReMend and with Balboa Nephrology and other entities around in the community in San Diego and Southern California region, that I just know that there's so many resources out there, and just make sure that you know that you can use them.
Thank you. Ms. Lupe, what would you like people to take away from today's conversation?
First, I would just like to add that I'm so grateful for everything that everyone is doing, that, on this panel, being of service and being there for people that really, really need love and compassion and support. My takeaway from my hope is that people would take away from today that compassion is what we need in order for us to recover, to change, to find that internal part of us that's motivated to make that difference. And so whether that is self-compassion, and I think Dr. Patel is really onto something of if you are, in a situation where you don't feel like you're being advocated for and you don't feel like you're being met with compassion, then to really, assert that part of yourself that says, in order for me to get better, I need someone to have compassion for what's going on for me. And that's going to help me have my own self-compassion. And so that would be my takeaway, is that, either you find it within yourself, which can be so hard. I can't even imagine when people are, really struggling with chronic illness, how hard it would be to find that internal self-compassion. But that's being gentle, that's having love, right? And then if you feel like the people in your corner that are supposed to be taking care of you and helping you with all of this aren't your advocates and aren't being compassionate, to advocate for yourself, that if I'm going to get better, I need these people in my corner to believe in me.
Right on. Thank you. Thank you for putting that so eloquently. I really appreciate that. I appreciate all of you for being here. We know this information can be overwhelming, but we hope it encourages you to focus on your self-care and your mental health and become your own advocate. Ask questions at your doctor's appointment, bring someone with you, record the visit on your phone, keep notes. I do those things, and I've been transplanted for almost 20 years. So I want to thank all of our amazing panelists. Thank you all. And I just want to give a shout out to Dr. Patel as well. Congratulations. He's the new CEO for Balboa Nephrology, guys. Amazing.
Congratulations,
Amazing.
Dr. Patel.
So
Awesome.
yeah, so I want to thank all of our viewers too for taking the time to educate themselves about mental health and kidney care. I'm going to share my screen again. It's a little private joke. Join us for our next discussion, which is going to be kidney disease research. What role does kidney research play? And in now and in the future, what are some new trial studies in kidney research? How can you participate? And what are some of the newest and best treatments in kidney care? So I just want to say thanks, everyone. Thank you, panelists. I appreciate you. And thank you for watching.
Thank you, guys.
Thank you, Kiku.
Thank you, Kiku.
Thank you, guys.
Thank you.
See you later. See you next time. Thank you.
Bye.
Bye.